So maybe I'll start with you, Erin, and maybe let's just talk about how to define corporatization. I think sometimes people who don't like corporatization think of it as kind of shorthand for badness and profit motive and rapaciousness. People who are maybe more favorable towards it think of it as imposing efficiency and effectiveness and structure. And so how do you think it's most helpful to define corporatization as it relates to healthcare?
Yeah, thank you, and thank you so much for inviting me to be a part of this. I'm a lawyer and not a physician, so I feel a bit like an interloper, although my dad is a retired internist who spent his whole career serving patients in private practice. And so my interest in this area comes from a long series of conversations that I had growing up with him, similar to Lisa's conversations with her grandfather. So delighted to be here. So in terms of corporatization and defining it, I recently wrote an article for the New England Journal of Medicine, launching a sort of a year-long series looking at the corporatization of the US healthcare system. And my task was really just to define what we mean by corporatization so we have a common understanding of what that term means. And I, in doing the research for that piece, looked at Paul Starr's definition from The Social Transformation of American Healthcare, where the second part of his book really looked at the rise of the corporation as a defining force of this sort of coming generation's understanding and interaction with the healthcare system. And so, that was written 40 plus years ago, and yet a lot of what his observations were just so prescient and just so predictive in some ways of where we find ourselves today. And so I drew the definition from his writing in that regard. And the definition I came up with was the increasing trend toward integrated control of the healthcare system by profit-seeking large consolidated enterprise. So it's this concept of integration, this concept of consolidation, meaning fewer large entities are making big decision-making and market-moving decisions on behalf of the healthcare system and directing those choices. So it's about size and scale. It's about integration throughout not just horizontal consolidation, but also up and down the supply chain, everything being combined into one large entity, whether it's an insurance company or whether it's a large health system, but all the data, all the physician practices, all the aspects of the healthcare system really rolled up into these large, ever larger enterprises. And then the other part of it is being profit-seeking. And so the idea of profit maximization, this idea of the shareholder primacy ethos being inherent in large corporate structure, to the extent that that is now sort of a central part of the healthcare system, we also see profit maximization becoming an increasing force in the practice of medicine as physician practices or the practice of medicine gets absorbed into these larger corporate enterprises. That profit motive or the shareholder primacy ethos also starts to affect or come into conflict with potentially the delivery of healthcare and professionalism. So that's sort of how I conceptualized it in terms of just descriptively. It's about scale. It's about sort of looking at who's in the decision-making, who has decision-making authority, who has power in these dynamics, and then what is the prevailing primary duty. And if it's the duty to maximize shareholder profit, there's an implied sense that sometimes might take precedence over maximizing the interests of your patient, which of course is the professional fiduciary duty.
That's really helpful. Troy, I want to bring you in just one second, but one follow-up question. I want to get your thoughts on whether nonprofit health systems can be corporate entities, and to the extent to which when they behave like that, is that because of something about the nonprofit health system, or is it merely that they're having to interact with all these external corporate entities? Because there's been no shortage of headlines over the past couple of years about the, many would say inappropriate behavior on the part of quote unquote nonprofit health systems that don't have shareholders in the same way.
Right. Yeah, so I think explicitly recognize that nonprofit health systems, when they get the same levels of scale and power of other corporate entities, can behave in a way that is indistinguishable from for-profit enterprises. And so in that regard, I don't think having a nonprofit form without shareholders immunizes a nonprofit health system from the effects of corporatization. If they behave in such a way where, again, the accountability is not to the community or the patients that they serve, but increasingly to a centralized corporate office, even if it is not one that is on paper dedicated to maximizing profit, they can have the same market power. They can have the same, frankly, profits that a for-profit health system does, and so can behave in a way that is functionally indistinguishable.
Yeah. Troy, anything that you would add or modify to that definition, or is there a different way that we should be thinking about it?
No, not really. I mean, I had the opportunity to read the New England Journal article that Erin wrote, and I think it was online. I would say just a couple of things about it, though. Mostly what Starr's book was about the hegemony of the medical profession and how that was bad for healthcare. And at the same time that came out, there was a whole set of reactions in the legal literature that suggested that it was important to have the sort of moderating influence of large institutions on the medical profession in order to make sure that things went right for patients. So there's real skepticism in a lot of places. Havinghurst, Blumstein, the former dean at the Harvard Law School, all writing about that particular sort of set of issues. But it also, if you go back to those days, to sort of '82, the individual doctors were all in private professional corporations. So their setting was a for-profit setting, and you begin to sort of ask yourself, at least I asked myself as I was reading Erin's article, sort of what is not, what is not corporate? In other words, okay, if you don't like this, you don't like these big companies and for-profit, then what do you like? And there's been a lot of reference to Marx, I think, in the previous discussions here. And I never liked the part in the Communist Manifesto where everyone was going to sort of do art by day and do a little bit of farming, and things were going to get a lot better. But that's not sort of how the industrial world's turned out. And so I just wonder, when you sort of worried about corporate influences on the medical profession, sort of what are you seeking? Because increasingly these young doctors do act like employees, and the most interesting sort of health policy fact of the last decade has been how there's been such a rush towards employment and away from sort of individual doctor practices. But I have to say, sort of like I'm here to represent the sort of corporate interests, I guess. And I was, sort of a strong leader and believer in vertical integration and, sort of helped lead one of the big companies, CVS Health, in that direction. We bought a PBM, we bought an insurance company, and we're in the process of buying physician practices. So I would have to sort of relate that I have certain biases in this regard and in this discussion.
So I think, obviously we're having this panel today because of a sharp rise in corporatization over the past 2 decades, however you define that. And the general valence is that that's been a negative thing for the healthcare sector. But then when I look back at healthcare of 2000 or 2005, it's not as if it was some kind of an oasis. We had medical errors, we had diagnostic errors, healthcare disparities were worse than they are today. Healthcare costs were rising. And so how do we pinpoint what's actually wrong with greater corporate activity in the healthcare sector? Is it a drive towards profits over patients? Is it that the locus of decision-making is further away from where it was? I guess my point is it's hard to blame all the ills of what's happening on corporatization when already we had a lot of problems back in 2000 or 2005 before this large wave. So how do you respond to that?
Yeah, so I think that, like everything in healthcare, it's complicated. And so there is as much as there's not a single boogeyman, there's also not a silver bullet, right, to address some of the complex challenges that we face today. I think that there is something there, though, in the sense that take I would say, the most extreme version of corporatization, which is the entry of private equity investment into both hospitals and nursing homes, as well as physician practices. And what we have been able to study thus far has identified certainly clearly that there are, that prices and costs from the consolidating effects of private equity investment can go up. That there is also this sort of short-term holding that private equity does, that sort of institutional investors may be buying and holding for the long term, and so they might have sort of more reputational capital at stake. But what we see, of course, is with the pinnacle examples of things like the financial collapse of Steward and Prospect hospital systems, and then the closures of certain hospitals, the patient harms that come from the kind of real estate asset stripping strategies. But in the physician practice context, we don't see the same sort of quality cliffs that we see when private equity buys physician practices, but we do see, I think this is where this conversation comes in, a change to the workforce. What is it like to work for a practice that has been acquired by a private equity company that is trying to, in a very short period of time, ramp up revenue and then sell and exit to another buyer? And I think that that's where we see some of these. Again, maybe it's not that private equity is altogether different in kind than other types and other historic forms of corporatization. We had PPMCs, back in the 80s and 90s. It's not like there's nothing new under the sun, but there's something about this sort of short-term, maximum profit. It creates this moral hazard that basically it's like other people, the investors are using, borrowed money and loading the physician practices or the other targets with this debt. And they make money whether or not the thing that they leave behind is sustainable, whether the workforce is happy, whether or not that it's going to provide good patient care in some ways. It could go bankrupt and they could still make money from their investment. So I think that that's where, maybe it's like the figuring out what are the most egregious harms or the worst risks are, to think about that, and maybe also to think about what is it doing to the profession that we see investors coming in, and this could be a good thing, right? A needed source of capital, a needed source of expertise. All of this information technology is very expensive, but the administrative burden of operating in such a system, of being a clinician, a rank and file clinician, seeing patients in a practice that is increasingly run by a corporate management service organization, can be demoralizing. And so I think that that's what I'm here to. I'd love to hear what the experience of the room is.
Yeah. Troy, I want to give you a chance to make the case that we should actually be thinking more along the lines of maybe not, let's say, private equity acquisitions of practices, but that some of the techniques, the management styles, the leadership structures, the way of thinking in the business sector should actually infuse more of healthcare.
Yeah, I'm going to be in a little bit of a box of me, the sort of corporate guy. So I'll take issue with Erin. I agree with a lot of what she had to say. Steward, buying a bunch of sort of really run-down Catholic hospitals and turning them for profit, that was a train wreck that everybody had to be able to see, and yet nobody saw. So I think that's a failure of regulation on the part of the Commonwealth of Massachusetts to let it sort of get started. But I tend to think of the paradigm more, and have for years and years, as fee-for-service versus sort of value-based. And where I see the corporate stuff really being really bad, both in the purchase of hospital and in purchase of sort of specialty groups, is when they do that and then they just put fee-for-service. So what you see is like they'll buy like a bunch of emergency medicine doctors and then do a lot of sort of surprise billing underneath in order to sort of drive profit. And those things are very profitable, and the VCs underneath that will make their money and they'll walk away and they won't care about it. For any of you who have ever been on boards of startups with the VCs, they're only looking at sort of the spreadsheets. So there's really sort of no doubt about that. But I do see sort of that there's our VCs and private equity that's supporting value-based approaches to healthcare. And I've been writing a long book. It's about ready to come out on primary care in particular. And when I look to practices that are either influenced, in other words, are taking direction from companies that are providing them guidance on how to negotiate in a value-based world or in the entities that are owned by big companies, including the Optum practices, I find people practicing in a very similar way and with a very similar approach to their patients and a sense of commitment to their patients as I see when I go to a big FQHC, and in many ways more so than I see when I go to an academic medical center. So I don't think that the sort of for-profit corporate top of the organization is necessarily sort of affecting care in the way that Erin's seeing it. In fact, I see those people doing a really good job and really sort of committed to their patients in a way that would make all of us sort of very proud. So maybe these people are especially good at sort of resisting, but on the other hand, again, you're a prisoner of your own sort of experience, and Lisa was saying about your own narratives. And at least from my point of view, when I worked for a for-profit system, we acted very much the same as when I worked for sort of for-profit corporations. You know, the name of the game in most of the hospitals that I worked with was, you know, do what we can to keep the ORs filled and get as big as possible, as quickly as possible, so as to get leverage vis-a-vis the insurance companies. And I still see those as the only strategies that most hospitals have today. So again, I go back to the question of, okay, corporate, but what is non-corporate? You know, where is the non-corporate? Maybe the answer is better regulation, and I'm certainly strongly in favor of better regulation of healthcare. But then, you know, you begin to run up against the Democrats, like the authors of the new book Abundance, who are concerned that we liberal Democrats are too oriented towards regulation. Maybe we're stifling innovation and growth.
Is there anything you want to respond to there? Or?
Yeah, I think I would just say that there is, you know, where is the, I think that's a good question of like, we've always had profit motive in medicine. It's not again, it's not a new phenomenon. And so in some ways it's not, some of the tools potentially of responding to it may also not be new. And I think we'll get into that here in a second. But I would also just say that there is some evidence that even among the physician practices that have been acquired by whether it's Optum or whether it's by private equity, particularly the primary care, that a lot of that is about, yes, it may be about providing better, you know, more integrated value-based care, but there also can be the experience that then your MSO is breathing down your neck to document all the diagnoses codes so you can maximize your Medicare Advantage risk-adjusted payments, which that can also be demoralizing, right? It's like, I'm not just a diagnosis generating machine, that the cog in the wheel phenomenon. And so all of these, it's not necessarily corporatization's fault, but it's also the systemic rise of Medicare Advantage, which has some. It's here, right? And so we have to contend with these systemic shifts that are in play as well. That it's not just about maximizing the number of reimbursements, but it's also about like who's making money off of the labor of the physicians.
Yeah, Troy, do you?
I'll just say on that though, there is, in primary care, I feel like I know it pretty well at this point. 400 pages later, I would say there's no empirical evidence of the particular point that you're making. When you go around, I mean, what did I do? I went to like 60 different primary care practices and talked to people. The coding issue, for example, it afflicts people in FQHCs just as much as it does people at Optum, and in exactly the sort of same way. They have questions about it, and they're concerned about it, and they want to be doing the right thing. And especially if they're living in a value-based world, they've got to be able to sort of code for the diagnoses that are there in order to get paid properly. So I would say, sort of evidence on a lot of these things is lacking. There's a lot of stat articles, that come out, and there's 15 different doctors they talk to who say, they're completely exasperated with having worked for Optum. But when I go to those kinds of practices, when I talk to those people, I would have been happy to sort of report that I saw the same thing that they did, but I didn't, And so I think, these questions are a little bit more open than at least the current press makes them seem. Again, to go to sort of Marx, German ideology, I'm a big believer in false consciousness, like Gramsci and Lukács, and I'd say that, there's been a scenario out there now that these corporate practices are bad, but I don't think there's good evidence on that. There's certainly bad corporate practices when people do things like what Stewart did. There's no doubt there. And there's also empirical data that quality suffers in some of those hospitals, and especially in long-term care facilities when corporate takes over. But I think I can separate those from some of the other things I see.
I didn't anticipate Marx coming up quite so much in this conversation.
Well, I wasn't the first. I just wanted to.
Troy, I want to get your thoughts on the ways in which professionalism intersects with corporatization. And do you see those concepts in tension? Do you see them as on parallel tracks? Or how should we think about this concept that, as I understand it, you wrote the charter, partially based on it, and the ways in which corporate activity is increasingly part of medicine?
Yeah, I would say on the charter, I did a lot of writing. I have to give David Rothman, now deceased, who's at Columbia University, and Jerry Kassir, who's still very much active in Boston, a lot of credit for their work on that as well. But the important part of the charter was, and it's interesting to sort of hear this whole discussion about sort of well-being, because the initial medical ethics was a sort of altruistic-based medical ethics that you were supposed to be putting your self, not first, but the patient's interests were the most important thing. And so there was this devotion to the patient. There was like a relationship that was outside of commerce, and that's where you get this sense that sort of corporate is something sort of separate, because the altruistic relationship, so that deontological relationship was the first part of it. The second part of it was the lawyers coming in and saying that individual patients had rights, and so the sense that patients had rights had to be part of sort of professionalism going forward. And then the third part that we really added was the social justice part, and that is you're responsible not only for the patient in front of you, but also for the system that you've sort of created, and to make sure that people have access to health care, and the health care was going to be sort of reasonably cost. And so I think, you take that to a sort of corporate setting, you've got to be thinking especially about that sort of third plank, which is, sort of are the things that you're doing making it possible for people to have access to health care, and are they making that health care less costly? And I think you can see that in a lot of corporate activities. I think where people really get twisted and inappropriately sort of torqued about corporate is that there is this whole for-profit part of it, and there's also this sort of sort of profit making by the executives. And there are people I know, people who I've worked with, who've taken hundreds of millions of dollars out of the healthcare system as sort of personal profit because they were the CEOs of big corporations, and they bought stock at a very low price, and the stock went up, and they made a huge amount of money. And that doesn't fit well with your sense of, I've got an impoverished patient here who I'm trying to sort of provide access to, and you think those two things just can't sort of fit together. But on the other hand, as I'm trying to say, sort of the corporate influences are meant to address what that structure of healthcare looks like to make sure that patients get what they need. And I think that corporations can have a strong role in that regard.
Yeah. Is there, do you see professionalism as something of a bulwark against the excesses of corporatization, or do you not see it that way? Like, is it not something that should be expected to stand up against some of the worst parts of corporate behavior?
At least in my jobs, I was expected to sort of be able to say, and I expected to be able to say, we can do this, we can't do that. And the differentiation there was based on sort of notions of professionalism, about what the responsibilities of the healthcare system are. And the one thing I say repeatedly in the stuff I've been writing recently is that if corporations don't figure this out, don't figure out that healthcare is different, can't get themselves in that notion of sort of the doctors sort of caring for the patient, then they're going to fail. I don't know exactly sort of what failure means. Maybe it just means more regulation, because I don't really understand what non-corporatization is. But you certainly sort of see it. I think they've increasingly sort of gotten their eyes opened, especially the executives. When one CEO of an insurance company gets murdered by a person sort of on behalf of patient good, they begin to sort of question exactly sort of where have we gone wrong.
Yeah. One last question. I want to come to you about some of the things that we can do on the policy front. What was it, you or people like you who had to make those decisions about we can do this and not that? Is it embedded in the culture or in the bylaws of an organization somehow? I'm trying to think of when there is the tension that arises that we could make a boatload more money doing this, or we could, we could do the right thing as we see it. Where is the responsibility in an organization, in a corporation, to make the right decision there?
Well, I've always argued in these healthcare corporations that you have to have a strong sort of medical department, a group of people who are sort of in the organization and making those determinations. And they have to be sort of empowered. I worry in some organizations you don't see that, and that's where the sort of corporate influences, the sort of, in particular, the sort of excess profit-making drive gets out of control.
Yeah. To the extent that we do want to rein in corporate activity, we can debate whether and how and if we should do that. But Erin, what are the kind of main mechanisms that are available either to organizations, states, the federal government to do that?
Yeah, so I think that, there are several different policy tools, but also to recognize that thus far, policy law, whether it's antitrust law, fraud and abuse law, corporate practice of medicine laws, have not stopped the onward march of the growing influence of large corporate consolidated entities. That said, there's been sort of a recent pushback, and I'm going to focus on the ones that are relevant to professionalism, just because of the conversation today. There are efforts, particularly to strengthen the corporate practice of medicine doctrine. So these are state laws that are on the books in most states, not all, that say, lay corporations, corporate entities, cannot go to medical school. They cannot take a Hippocratic oath. They do not have ethical professional duties to patients or to communities. And so therefore, corporations should not own or employ physicians, because doing so would exert too much corporate control over the practice of medicine. So this is a long-standing historic doctrine. It's been both, I think, powerful, but also in some ways abused to kind of create this, professional guild system. But it also has been eyed in recent years as a potential way to protect clinical autonomy and professionalism from corporate influence, because it's like we have this doctrine on the books in many states. Yes, it's been sort of laying dormant and under-enforced, but could it be used as a way to protect clinicians who are trying to balance and weigh these conflicts between what is best for my patient and what is best for my boss in a way that preserves their moral integrity? And that is to say that there are certain types of clinical decisions, there are types of organizational decisions that impinge on clinical decisions that the management service organization or the corporate entity cannot do, to really strengthen that. And the most recent example of this is the state of Oregon just passed this legislative session, SB 951, which is a law to strengthen the corporate practice of medicine doctrine in Oregon, to prevent, for example, management service organizations not only from owning and employing more than a majority of the physician practice, but also from, doing the types of deciding scheduling, deciding compensation, saying what physician owners of their practice can or can't do with their shares in their practice. Again, not saying that the management service organization cannot provide any administrative services or can't do billing and collection or payer contracting for the physician practice. But if the physicians ultimately say, we don't want this, we don't want to go out of network with this payer, or we don't think that, moving from this scheduling system to this one is in the best interests of our patients, we can push back on our service provider and say, no, we don't want to do that. So it's really just sort of putting some guardrails around what management service organizations and corporate entities can do, at the over the sort of protest of the physicians that they are managing. Again, still being able to provide those management services, but to restore the principal-agent relationship where the professionals are the ones who get to say, this is not good for patient care, so we're going to push back. So that's one way I think that we're seeing some evolution here, because for so long the corporate practice of medicine doctrine has done really nothing to prevent the sort of encroaching control over the practice of medicine, the day-to-day practice of medicine. And to be honest, a lot of physician practices are like, we don't want to deal with this stuff. We don't want to do, procure our HR, or do our HR services. We don't want to do billing and collection. Please, someone take this administrative burden off my plate. But, the figuring out where the boundary is between when those administrative and operational decisions start to, put in place friction on that sort of internal delivery of care, that judgment. That's when the these new laws are trying to strengthen that line and that boundary. So that's just one example, I think, of a policy.
I have one more question, then maybe we'll take questions from the audience as well, so if you want to start thinking about those. I want to get your thoughts on two other things, and Troy, if you have thoughts as well, but one is physician unionization, and so this idea that over the past, I think, 5 or 10 years, there's been a very sharp rise in unionization, and the extent to which you think that has been effective or might be effective. And the second is federal antitrust activity and trying to intervene in some of the mergers that either are going to occur or have occurred. Where do you see that fitting in?
Yeah, so I think unionization is a really big, is probably another huge policy lever, particularly as physicians move from, I guess we're all Marxists, or talking about Marx today, from realize that they are labor and not capital. I think that is a generational shift where physicians are increasingly seeing themselves realizing that they are a labor input, not the sort of the managers of the healthcare system. And if that's the case, particularly if the rise of the actual numbers of physicians in employment relationships rather than as independent practice owners, that sort of the unionization is the key. The employment protections you get from unionization can be a lot stronger than just the corporate practice of medicine doctrine, right? If you're an employed physician, it doesn't really matter if your boss is your boss. What an MSO can tell you what to do. If you also can say, use your collective bargaining to be able to advocate for staffing protections and other types of things that are what physicians and other clinicians can sort of join forces to say this is what's in the best interest, not only of our working conditions, it's not just about compensation, it's about staffing levels, it's about what we think is necessary to provide good patient care. So I think that's very important. And on the antitrust side, I think there's also been a continuing evolution of the antitrust authorities at the federal and the state levels to go after novel forms of consolidation and integration in the healthcare system that may have these sort of controlling effects. The biggest example, I would say, in the corporatization and physician world would be the Federal Trade Commission's action against U.S. Anesthesia Partners and their private equity backer, Welsh Carson. Welsh Carson was dismissed, secured a dismissal from the case, but the idea of this sort of platform and roll-up strategy that private equity is using to consolidate physician markets can have anti-competitive effects, and the Federal Trade Commission is testing currently this concept that some of these smaller transactions and this type of commercialization or consolidation of the market could potentially have anti-competitive effects is a case to watch. It hasn't necessarily been resolved yet, so I think that's
Thank you.
Interesting.
Just on the three things. One, the corporate practice. The corporate practice was something that the initial sort of legal influences in the 80s and late 70s and early 80s were pushing against, because they thought that that just was basically sort of supporting the profession. But be that as it may, okay, so doctors don't work for corporations. Let's say that that's what the Oregon law says, and others do that. Where are they going to go to work? They're not going out of medical school and setting up shop, putting out a shingle. They're going to look for employment. They're going to be employed by the hospitals. That just gives the hospitals much more sort of bargaining power vis-a-vis the commercial insurance companies. There's a previous book I wrote about sort of evolution of insurance companies. I just sort of see that as the hospitals get more powerful, they bilk more from the commercial insurers, and slowly but surely that's going to lead to federal-dominated payment system, with or without corporations, either a single payer or something that looks like universal Medicare Advantage. And personally, I think that's where we're headed anyway, so this might just make it go faster. But I don't think it changes anything in terms of sort of what the expectations are going to be, because if you're running, the hospitals are now run by administrators as well, and they think a lot like the people in corporations do. With regard to sort of unions, I did talk to a number of primary care doctors who are unionizing, and overall, especially at this FQHC in Washington, D.C., it seemed like a very good idea. You know, it was the only way they were going to get paid more, and they were going to get work conditions that sort of made sense for them. And so I think getting union protection is important. Just realize there's nobody in gastroenterology or cardiology, and certainly not in any of the surgery, who's talking about unionization. It's all primary care, because they're not getting paid enough, and their work situation is terrible in a lot of situations. So we could see, I think, a healthcare system that sort of evolves in the direction if you get a bunch of unionized primary care doctors, and then the wealthy people, because the other, he's not necessarily a Marxist, but Piketty comes close to being one, you know, the concentration of wealth in the upper 20%, upper 10%, they're always going to be able to buy concierge. That's the other big movement in primary care today. And so you could see a real sort of bifurcation of the healthcare system, which I think would be incredibly ugly. And on the antitrust, you know, the big question is, you know, this current administration is horrible, horrible from my point of view in a lot of different ways, but it's unclear what they're going to do about antitrust. They could go ahead and break up the vertical integrations that have occurred. No one's showing much appetite in sort of going after horizontal, especially on the hospital side. I don't think that they'll be active about that, and so I don't think you'll see sort of new uses of the antitrust law over the course of the next 4 years, but the rest of the stuff they do in healthcare is going to be very, very bad.
Oh. Well, on that note, questions from the audience?
Oh, okay. Hi, Kathleen Noonan. I run the Camden Coalition, and I'm a lawyer. And so I've seen medicine as a corporate practice for a long time. I'm actually, this question is really for Troyen, and I see two different types of sort of venture practices out there. I see the venture practices that are coming in that plan to stay. And I see the venture practices that feel a little bit more like extraction economy. You know, they're going to make a lot of money. It feels like a gold rush, and then they're going to leave. And so I'm just interested in how you segment the different sort of venture trends out there in healthcare.
Well, the venture people are never in it for the long term. So, you know, by definition, they're making 10 bets. They're hoping one or two sort of come through. There are some venture people and some private equity people, you know, meaning larger firms that come in and actually sort of take over in a real corporate fashion, who think that they have to be patient with things like managed care. So, like the original investors in Agilon, for example, or today's venture investors in Aledade, both of which are companies that are aimed at trying to help primary care practices sort of deal with value-based care. And they walk the walk, they talk the talk, they walk the walk somewhat. But I think it's the big, you know, and this is where I sort of agree with Erin, it's the big sort of Achilles heel here is that, you know, if you're a believer that value-based care can eventually take over, you got to be patient, because it still hasn't done much over the last 30 years. We've been sort of talking about it. But you've got to have some patience. And there's at least some situations where people are making, you know, relatively sort of big money betting on value-based approaches. And there's some evidence that those value-based approaches are working. So I have at least some confidence, not complete confidence, but some confidence that this can actually be an important contributor in primary care. And this primary care book that I've just finished, I've tried to write what's the federal government's doing, what are the state government's doing, what are the small insurers doing, what are the big insurers doing, what is venture doing. And you can find, in each of those areas, you can find sort of good things happening. You can also find a lot of lethargy or inertia.
Hi, Asher Tulsky, ABM Foundation trustee. Actually, Troyen, you sort of anticipated my question, but it's really directed towards Erin. Do you see similar corporate influence with single-payer programs like the UK's National Health Plan or even the VA here? And maybe those are models that are alternate to be looking at.
Yeah, I think that what we are seeing that, for example, private equity is a global, its interest in healthcare is a global phenomenon, but if you try to figure out where in, say, the NHS system, the interest of investors is, it's in the sort of, it's not in the hospitals, it's in the sort of less regulated, more market-driven aspects of the care delivery system, same in Canada, same in other places. I'm not sure exactly on how much we're seeing private equity investment, for example, target community care providers that are heavily used by the VA, but we do see that there is, again, the interest of private equity tends to be in places where there's a revenue or an extraction opportunity. And so in the Medicare system, it's in Medicare Advantage more than it's in traditional fee-for-service Medicare, although there are opportunities in fee-for-service Medicare, so it's not exclusive to that. There's, Part B, ophthalmology payments, and there are all sorts of little loopholes to leverage. So I think it's less about changing the organization and the payment system to be single payer versus not single payer is somewhat orthogonal to the question of whether or not there are profit opportunities to be made within that system. Because I think the answer is there are still profit opportunities to be made in a more regulated system. Maybe it can be constrained in some ways, but again, you create a payment system and you create loopholes and incentives, and those can be exploited.
Touch it. Susan Edgman-Levitan, Foundation board member and director of the Stokel Center at Mass General Hospital. And I have a comment for Troy. There are specialists in Boston talking about unionization because of concerns about corporatization and administrative harm that are affecting them, although differently from how they're affecting the primary care clinicians. But my question is...
Maybe the ID docs.
No, it's more than the ID docs, but we can talk afterwards. But my question for you all is, you haven't said much about the role of board members and boards in all of the decision-making and the leadership and management of for-profit and not-for-profit. And I know from Don Berwick, our colleague here, that only about 14% of boards have any clinical expertise on them, or board members. So can you say something about that and what role they might play, how they might help mitigate some of the issues that we're talking about here?
You want to start?
Well, I'm not. Boards, I'm bad because I never really liked the boards. And I've been a board member at a bunch of different places, nonprofit and for-profit, and I'm a miserable board member. And I always end up either getting tossed off or quitting. I mean, I think you can use the board in certain circumstances. Like when we were trying to get rid of tobacco in the CVS stores, I used the board people there to get some help because they had a little bit of a sort of outside perspective, but mostly from sort of a public relations point of view. I don't count on the boards of the I wouldn't count on the corporate boards, and I won't count on the boards of the nonprofit hospitals to really provide sort of much influence on these things. I hate to be sort of cynical about it, but I just can't, I just hasn't been my experience.
I think that that's one, it's, again, there's no silver bullet. I think simply changing the board representation to include more clinicians, more community representation, I think it would be helpful in the sense that there has been a couple of comparative studies about hospital boards in particular that have clinical representation might make certain decisions that are differential than the ones that are financier based. But I think they're also operating in an environment where, they're answering to, if it's a nonprofit health system, they're answering to their bondholders. So there's and they're making decisions that are about their bond ratings, and those are decisions that, again, whether you have clinicians on the board or financiers on the board, the idea is, what is the what are the incentives for the governance structure? But I think thinking about governance is actually a really important question if we think about how do we, prevent sort of the adverse influences of corporatization while harnessing sort of some of the necessary capital infusion. And that's, I think, governance is a big one. Governance is I think we've relied on it too little, and we've insisted too little on the community, benefit standard for tax exemption, for example. So in some ways that there are opportunities or future levers to kind of push more forcefully on those areas.
Richard Barron, after a career in community practice, I spent the last decade leading this organization in ABIM. A question mostly for you, Troy. You have a very unusual career, I'll say, from the charter to the head of CVS Aetna. Our aspiration for this meeting is that individuals in their settings and leadership positions will animate values in decision making. Can you describe, and this is a personal question, you can dodge it if you want, a situation at CVS Aetna where you were a leader drawing on the values that you were talking about in the charter in a complicated way to drive the corporation? Dhruv asked you, you decide we can do this, we can't do that. Can you share a story that would inspire people to exercise moral leadership when the opportunity presented itself?
Well, we dine out of several of us executives former executives from CVS on the tobacco thing, and that was a good thing to do. It took a long time, but I would actually say something more. It might seem quite paradoxical. In like 2010, 2011, it was occurring to me. We just bought the PBM, and the formularies were being set. Sort of like the PBM wasn't really necessarily sort of being allowed to exclude any drugs off the formulary. That was thought to be a client decision. But the contracts, I read the contracts. Contracts didn't say it. It was something that we could do. And so we at CVS convinced the PBM people that we could basically sort of exclude drugs if we wanted to. And by excluding drugs, when you do that, especially if you've got a situation where you've got two branded drugs competing against one another, simplest situation, the branded insulins competing against each other from Novo and Lilly, they're exactly the same. They're engineered to be human insulin. So they're exactly the same. The only thing that's different is the pens you use to sort of inject them. If they're exactly the same and we exclude one, we'd be able to get a much better rebate and as a result, those rebates, at that point, 80%, 3 years later, 98% of those rebates went back to our clients, lowered healthcare costs, allowed them to do other things for their patient populations in the corporation. So and so the question was, can we do this? Can we and we did. And I, in terms of looking at it, would reflect professionally on, you've got to develop a healthcare system where you're doing something to sort of control the costs. Because if you let the costs just continue to go up as they do in fee-for-service, sooner or later, everybody's not going to get access to healthcare. And that's the sort of the worst part of it. So I would say that was a situation where in something that's become something that people really dislike today, which is these exclusions of drugs that PBMs are doing. In fact, we got sued by not only our own clients, but the other PBMs refused to do it for a year or two until they saw that it was going to become sort of acceptable practice we do it. But it was something where you take sort of the notions of professionalism that existed in the charter and you apply them to a corporate situation. They said, this is something you should be doing. So I think, a lot of people would say that's just a purely sort of corporate thing to do to sort of make more money. But if you're thinking about things from the point of view of being in a corporation and applying sort of a sense of structural professionalism to them, it's something that seemed quite sensible.
Sorry. Hi, Margaret Flinter, long-time, decades-long FQHC leader and clinician, nurse practitioner, and I'm the board of trustees here. First of all, it's wonderful to have somebody even mention FQHC. It doesn't get mentioned a lot in these circles, and I appreciate your knowledge of them. I think I wanted to comment that the for-profit, non-for-profit are both corporations. You're absolutely right. But I'm going to make a pitch for the nonprofits, even those that aren't FQHCs, right? It's not about making a margin. It's what you do with the margin, right? The investment back into versus disappearing completely out of the system is kind of at the heart of the underinvestment in private practice, right? And I think that there is an alternative path for practices to control their own destiny. But I think they have to adopt a couple of things, and society needs to do a few things. I think what private practices, privately owned corporations need to do is rigorous reporting, similar to what the community health centers have had to do for 50 years and gotten better and better as technology enabled it, to have strong representation on their boards, and I really couldn't agree more. Boards have a very important role to play, but they've got to be decision makers. They may not be 51% majorities, like in the FQHCs, who really control decisions, but they've got to be really strong decision makers, and I think we've seen with the rise of teaching health centers as opportunities to train the next generation of clinicians, both physicians and nurse practitioners, PAs, and everybody else. There is a hopeful path there. So I'm not sure I have a question left after all the previous comments that were just made, but if it was any, it would be, do you have any confidence that we can see the rise of a truly, if nonprofit, at least, what's the intermediary form now for value-based equity companies, right? Social investment companies that can really do something that right now we're just not seeing with the people who create and own the for-profit structures. Thanks.
I agree. I think there's a larger role both for sort of public provisioning generally, you know, FQHCs, community health centers, and sort of the public investment, the public dollar that is really fueling a lot of the provision of healthcare in this country, I think is under-recognized and probably needs to be, you know, celebrated and maybe a little bit more protected. And then I think there's also the idea of like benefit corporation or other types of corporate structures where stakeholders and not shareholders can also be considered in the range of fiduciary duties. So you're not just trying to, in a Friedman-esque way, maximize shareholder value and returns, but also think about how this affects the community, the workers, the patients, who are the huge stakeholders in our healthcare system for a social good like healthcare that we all depend on.
I think we have time for maybe 2 or 3 more questions.
Hi, I'm Lucy Lycom. I'm from Texas, and I see people in the primary care and inpatient settings. I have an academic background, but for the last 3.5 years, I've worked not only in academics, but at a VC PE-funded startup, value-based care. And so I have some sort of reactions to your comments, but they're really more for the group, for our conversations in the next few days. And the first is really thinking about what is the task of these larger healthcare delivery systems. Because it's not only to take care of individual people, but it's to manage risk, right? We have performance risk, we have to manage risk. What does that mean for care delivery? Larger populations, data, control over the healthcare delivery infrastructure. And what does professionalism mean in that setting? Because it's not just individual versus the organization, but it's a change in the task. So I'd say that is one. Second is, who is innovating? I thought a lot before joining this startup, and a lot of the incumbents where many of us work are not innovating. So what is our role as professionals in really putting forth that agenda of how are we always trying to do better? And then the third is a reaction to why don't we see more differences in outcomes? And some of it is that all of these delivery systems are grappling with the same tasks, but some of it is that we haven't defined what the outcomes are yet. What are they? How do we assess them? What do they mean? And I think that's another place for us as we think about professionalism and what it means to really have an active role in that conversation. So thank you.
Thank you.
Oh, I held it, man. Jeez. Okay, hey, I'm Neil Shah, Maven Clinic. I run a large venture-backed startup, and I have a lot of similar kind of thoughts, but one of them goes back to the original definition of corporatization. And as you spoke to it, integration doesn't sound like a bad thing. Disintegration sounds worse. Consolidation isn't automatically bad. It's at least neutral. Like, nobody wants monopoly, but balkanization is bad too. And then there's the profit seeking, which I think we're starting to complicate, but is at least complicated, if not automatically bad. And so one of the thoughts that I had, I mean, maybe it's a facetious question, Troy, about like what is the alternative to corporatization? But to me, I think a differently framed question is, how do we take some of the inherent structures of the corporatization, integration, consolidation, profit seeking, and enable professionalism rather than automatically seeing them as barriers? And maybe the answer is in partly what Rich was sort of calling to. I mean, I'm looking around and there's multiple people here who are in corporate structures and venture-backed structures and PE-backed structures who are trying to carry a lot of these values. And we need the capital of shareholders to do disruptive things that kick a calcified system in the butt that's not innovating or whatever. And so I think we just have to think about this in a way that is at least acknowledging the fact that the complexity of the modern healthcare system, the technologies that none of us might have imagined even a few years ago, from generative AI to GLP-1s, are compelling a re-engineering of the way that we organize and finance our system. I think that might be a better framed way to think about it.
I would just say on that point, sort of like I've been a little bit too harsh on boards and corporate ethos and things like that. But if you look at a place like City Block, and just take a look at their principles, which are featured on the first page of their website, and then you talk to the people in that organization, they're actually sort of it's an organization that's intended to provide care for impoverished people who haven't gotten care in the past. It's supported by nearly $1 billion of venture capital. But the people in the organization, take energy from the commitments that they see there and the commitments that their executives sort of repeat whenever they talk. And I think that's the kind of thing where you can find sort of a reasonable sort of middle path between what might be considered sort of profit-driven sort of capitalist investment and real commitment to patients.
Whoever thought of the don't touch the mic should be retired. So I was the former EVP at the ABIM Foundation. My name is Daniel Wolfson. But before that, I was the president of an organization called the Alliance of Community Health Plans, who represented non-for-profit group practice HMOs from around the country. So we did a study by Brad Gray, and we used the HEDIS information, and the group practice HMOs, all not-for-profit, exceedingly beat everybody in the field as far as quality and in cost, and nobody cared. The public did not care. The employers didn't care about the distinction between not-for-profit and for-profit. So any data, my question is there data on performance between not-for-profit and for-profit, because that's what we're really interested in, and any information about what the public or employers think about this issue of for-profit, not-for-profit. And by the way, it was always about the group practice nature, the structure, and the prepayment. That's what differentiated us.
You want to speak to the data point?
Yeah, I mean, I don't know if there's, in terms of the data comparing, nonprofit versus for-profit, depends on of what type. I think there's probably more on hospitals than there is on other type parts of the care delivery system. There's been some recent, also with things like hospices that had a traditional nonprofit organizational form and then have increasingly become for-profit over time. But I think nonprofit versus for-profit isn't solely the distinction between corporatization versus not. There's like, it's an overlapping Venn diagram, but it isn't necessarily indicative of, yes, some nonprofits can be highly corporatized and they can functionally be indistinguishable, and others take their charitable mission very seriously. And so I think that in some ways it's hard to measure differences when it's not the factor that necessarily distinguishes the corporate culture in these places. But I think in terms of, I'd be curious to hear what Troy says about the employer and the purchaser side of the equation in terms of their perception of this trend.
Well, I agree with Erin completely, and the data on, but it does point out the problem. So I know what profit versus nonprofit is. I don't know what corporatization versus non-corporatization is. So the corporatization thing gets hazy, and that's my major sort of discontent with using it as a sort of a fulcrum for trying to analyze the healthcare system. But it is clear that nonprofits have generally sort of outperformed for-profits in a variety of different sort of settings. The problem in the hospitals is you've got only two or three really big hospital chains actually do a pretty good job on most of their performance measures. But the place where I always like to point out is Kaiser. Kaiser is a nonprofit. It always outstrips the other insurers in terms of the quality of care that's rendered on the measures that we sort of have available. So there is something to be said, I think, for making people feel like they're part of a program that's oriented towards the good, and at least a nonprofit organization probably has a little bit better chance of that than a for-profit. But as I said, the appropriate sort of for-profit can pull that off.
Well, thank you both. Please join me in thanking Erin, Troy,